Now, with Fanconi, further definition, generalized dysfunction of PCT due to cellular energy metabolism might be lost. Remember, the PCT is the segment of the nephron that requires quite a bit of ATP, doesn't it? Because it requires that basolateral membrane, sodium-potassium, ATPase pump to generate that symport and antiport and so forth. Results in impaired reabsorption of almost all of your substances and may result in all kinds of issues. Maybe idiopathic, maybe you have drugs that may then cause toxicity. Multiple myeloma, which is one of your, we'll talk about this as being a paraprotein type of issue. And multiple myeloma, we'll talk about Benz-Jones-like proteins. You have your Kaplan-Lambda, we'll talk about that in great detail. This may then cause damage to the PCT along with your myeloma CAS. Don't worry, all this is to come. And it might be an inherited disorder. Now, this is interesting. Pay attention. The most common is cystinosis. So, an inherited disorder in which it may cause damage to your PCT, inherited, is cystinosis, a rare disorder of cystine deposition in tissue. So, in an inherited disorder, cystinosis, there might be generalized damage to the PCT. All this is saying on this particular slide is the fact that we have numerous causes of Fanconi syndrome. What does this mean? It means generalized dysfunction of the PCT. What are you going to find in your labs? Pretty much everything's decreased. Your pH is decreased. Why, please? Because you cannot reclaim your bicarb. What kind of RTA is that? Renal tubular acidosis. May I ask you something? What if you took that drug called acetazolamide? When did we, you and I, give acetazolamide? Who was that patient? High altitude. To do what? To facilitate the renal compensation, right? To facilitate the renal compensation to get rid of the bicarb in that patient that had a respiratory alkalosis. Are you with me? Good. If you're getting rid of your bicarb in that patient with acetazolamide, technically speaking, what are you creating? A type 2 RTA. What if you had a patient, listen to this one, and the boards or the wards or whatever would ask you such questions? Think, what if you had a patient who genetically was missing carbonic anhydrase? If you're genetically missing an autosomal recessive disorder in which your carbonic anhydrase is missing, what happens to your renal threshold for reclaiming bicarb? It is decreased. What kind of RTA is this? RTA type 2. You see that? So all that RTA type 2 means to you is the fact that, well, it's just a consequence of many diseases of the proximal cavity tubule. Be smart about how you approach the diseases. Keep a bird's eye view. Do not dive into the details immediately without first understanding the big picture. Next. In Fanconi, you're going to lose everything. Polyuria, polydipsia, dehydration. In other words, that's a lot of solute in my urine. You tell me what kind of diuresis? Osmotic diuresis. Pathologic, of course. You give me a diuretic that provides osmotic diuretic, or as works as osmotic diuresis. Mannitol. Multiple metabolic issues. We talk about metabolic acidosis. What kind, please? RTA type 2. Your next step is this. You ready? So you find your patient having metabolic acidosis. What does that mean in terms of pH? Decreased. What does that mean to you specifically? You have your pH being less than 7.35. So they'll give you something significant, like maybe 7.2. So for sure you know your acidosis. You take a look at your bicarb and it's less than 22, maybe 18, maybe 15. So now you have confirmation of metabolic acidosis. Are we clear? And so therefore, how would you then compensate? Well, the compensation would be immediate with respiratory blowing off with hyperventilation. Are we clear? Good. Fanconi syndrome, RTA type 2. Hypophosphatemia, you're getting rid of your phosphate. Remember, you lost your homeostasis of phosphate in the PCT. Indirectly, you might end up losing your potassium, hypokalemia, and may result in hypocalcemia. Remember, the reason that we have bone next to calcium and phosphate, how do you form bone? How do you make your bone extremely strong? It's called hydroxyapatite, correct? Hydroxyapatite. What does that actually mean? The combination of calcium and phosphate, so a proper mineralization of your bone. You end up losing your calcium and you lose your phosphate, your bone's definitely going to be affected or influenced. So you can see Fanconi Syndrome is a wonderful disease in which we can integrate and bring in a lot of issues all at the same time. Major complication, we talked about the bone formation, resulting in growth impairment and perhaps even failure to thrive. Let's talk about a couple other diseases here of the PCT. We haven't left PCT yet. Now we have HARTNUP. Well, I'm not saying HARTNUP because in HARTNUP you cannot properly reabsorb tryptophan. Got that? P and P. HARTNUP, tryptophan. So these are neutral amino acids, specifically tryptophan. That's what you want to pay attention to. The other one will be cystinuria, inherited disease. You cannot properly take up a basic amino acid, and there's a nice little mnemonic here called COLA, C-O-L-A, or whatever that you may want to use, in which apart from cysteine, you may also not be able to properly take up ornithine, lysine, and arginine. You shall see. So still in the PCT, you're not able to properly take up your tryptophan and HARTNUP and cystinuria with the mnemonic COLA. Let's take a look. Both diseases, you end up having issues in the PCT. It's inherited, autosomal recessive, and a defect in the fact that you cannot properly take up these particular amino acids.